Dr. Hwang, colorectal cancer is believed to occur in older individuals. However, recent studies and stats suggest that the burden of disease is shifting to the younger people. Is this true? And if so, can you talk a little bit on why this is happening currently?
So it's sort of true, but it's not really true. The median age of diagnosis for colorectal cancer is actually still around 70 years old and continues to be that way. Some studies suggest it may even be a little bit older than that. So most patients that are diagnosed with colorectal cancer are still very much on the older side. Having said that, it does appear that over the course of the last 2 decades, since about the mid-1990s, more patients have been diagnosed with, more younger patients, that is, the younger being defined as 55 and under, have been diagnosed with colorectal cancer. So over the last 20 years, certainly there have been more patients that are younger have been diagnosed with colorectal cancer. The reasons for this are not entirely clear. I think that certainly there are hypotheses that relate to either diet and or exercise, recognizing that those are 2 trends that we've seen in this country over the course of the last 3 to 4 decades, changes in dietary habits as well as changes in exercise habits. I think that there are other hypotheses that relate to probably still, at least indirectly relating to diet perhaps, that relate to perhaps gut bacteria and whether that has an influence on the development of malignancies. But the most honest answer when I talk to patients or anybody about it is the reality is we don't know.
Mm-hmm. Because why this is my first question is because when I was reading up about colorectal cancer, there was also a hypothesis that probably this kind of change in age group that we are seeing is also maybe because of improved reporting now, because of awareness increase. Is that, can we also say something of that sort?
Well, that's always difficult to prove one way or the other, at least in the short term. I think that if we see that the numbers fall off over the course of the next decade, then that would suggest that there hasn't, in fact, been an increase in the number of total colorectal cancers, just that there was a surge in reporting. But I've not really seen a whole lot that suggests that that's necessarily the case. I think when you look at some of the different curves that have been published through the Journal of the National Cancer Institute or through the American Cancer Society, it looks to be a pretty consistent trend over the course of the last several decades, and that would make me really question whether that's just a reporting thing, fact. I think that it does really seem like it's a real effect. And then the other thing that would make me say that is a fair number of these patients have advanced disease when they are diagnosed with their colorectal cancer, which would suggest that they have symptoms, that it's not earlier diagnosis of an early stage disease.
Yeah. Dr. Hwang, what we want to do is actually take a deep dive into some of the available treatments and work that is being done where you're doing at Levine. But before that, just to give the audience an idea, just in layman terms, can you please explain what colorectal cancer is, and then touch upon some common symptoms as well as tests that can be done for diagnosis?
So, and this is actually an analogy that one of my colleagues came up with, and I actually like it very much. I think that if you go back to 2009 even, but probably even longer than that, if you go back to 2000, pretty much everybody thought of colorectal cancer as being one disease. But what we've learned over the course of the last decade and a half is, as my colleague puts it, colorectal cancer is really more of a family name, and that is an umbrella term for different cancers. Now we know that rectal cancer is not quite the same as a left-sided colon cancer. A sigmoid colon cancer is not quite the same as a right-sided colon cancer, and then there are different mutations that we've learned about. So colorectal cancer is sort of an overarching name for a set of diseases that are very similar but not necessarily exactly the same, and that's also reflected in how they present. So some patients may present with nothing, and we find the cancer has been found at the time of screening. Other patients may have some changes in their bowel habits. They may notice, for example, more bleeding with their bowel movements or pain with their bowel movements. We see that more often with rectal cancers than we do with right-sided colon cancers, for instance. Some patients may present with just more fatigue. They're found to be more anemic. We see that more often with right-sided colon cancers, for example. And then there are some patients that are found when the cancer is already spread, and sometimes patients have symptoms from the fact that their cancer had spread. Was there
yeah. Yes, doctor?
Yes, I think that covered the question. Yeah.
Yes. Okay. Yeah. So what are some of the diagnosis tests that we do to actually diagnose this as a colorectal cancer?
Sure. So, again, it depends a little bit from a screening standpoint, from a diagnostic standpoint. Diagnostically, probably the most common test is the colonoscopy, or the shorter version of it is called a flexible sigmoidoscopy, but that doesn't get as far to look inside the colon, so it's not always quite as good a test. Usually we use those when a colon cancer is suspected because a patient is anemic, because a patient is having trouble with their bowel movements. But other tests that can be used for screening, for example, include stool testing, either for blood or for or even for now colonic type DNA. Once the colon or rectal cancer has been identified, other tests that are used for evaluation of the tumor, the evaluation of the extent of the tumor include CT scans, the so-called CAT scans, as well as sometimes in some circumstances what's called a PET scan, a positron electron tomography, positron emission tomography, is used in certain circumstances, but not necessarily as the initial test. One test that we often look to see if it's something that's helpful, although it's not always helpful, is something called a CEA, or carcinoembryonic antigen, which is actually a blood test. But from a diagnostic standpoint, I think the key tests end up being a colonoscopy and then CAT scan.
Okay. We actually have a listener sending a question regarding this. He wants to know, when should a person begin regular colonoscopies? I think, again, this is screening perspective.
Sure. No, that's a great question. I think it's an important question. Part of it depends on who you ask, and part of it depends on a patient's history, and quite possibly on their ethnicity. So if you go by the most recent American Cancer Society recommendations, everybody should start screening at the age of 45. But there's one very important exception to that, which is patients who have a family history will very much alter family history, or if they have a known genetic mutation, may very much alter those recommendations. So if somebody has a family member who was, for example, 50 when they were found to have a colorectal cancer, then the recommendation is that their first-degree relatives, that is their siblings or their children, should get their first screening study at 10 years younger than that. So a patient who's been identified at age 50, their child should undergo screening not later than age 40. And frankly, if they have any symptoms that are suggestive of colon cancer, they should probably be evaluated sooner. If somebody is known to have what's called Lynch syndrome or hereditary non-polyposis colorectal cancer, the recommendations are to screen even earlier than that. So it does depend on that. And then the recommendation for screening to start at age 45 from the American Cancer Society recommendation. Before that, though, there were suggestions that African Americans should actually be screened younger than the general population. So before 2018, the recommendations were actually to start screening at age 50, and that African Americans should perhaps start screening at age 45. When they moved down the screening recommendation for the general population to 45, there has not been a subsequent recommendation to lower the age in African Americans. Although I think that's certainly something that is being discussed.
Yeah. So once diagnosed, after all the tests that you mentioned, what is the current standard of care for colorectal cancer?
So that's where things get a little confusing. That's why I go back to that analogy of colorectal cancer is an overarching term for a family of cancers because what we do depends on the stage of the cancer, and it does depend on where the cancer is. A rectal cancer is treated differently than a colon cancer, and what order we do things may depend as well. So if you're talking about a rectal cancer that hasn't spread further than any of the local lymph nodes, for example, what we call stage 2 or stage 3 rectal cancer, then a lot of times patients will end up getting some combination of surgery, radiation, and chemotherapy. If they have a very, very early stage rectal cancer, they may not need the radiation and the chemotherapy, or perhaps, although this remains unclear right now, maybe they don't need the surgery. Maybe they can only do the chemotherapy and radiation. On the other hand, a colon cancer depends very much on how advanced the cancer is. So if it's a very localized colon cancer, surgery alone may be good enough. If it's a more advanced colon cancer that's spread to the lymph nodes, then most of these patients will recommend somewhere between 3 and 6 months of postoperative chemotherapy. But if the cancer has gone away from where it started to a distant organ, to the liver, to the lungs, to the bones, then the role of surgery is less clear, and the primary treatment is chemotherapy, sometimes with the addition of radiation.
So we have a listener asking a question regarding this. What are some of the risks of colorectal surgery?
So that depends on where the surgery is being done, like literally anatomically. So for a colon cancer, anytime anybody gets cut on, risks will include pain, will include bleeding, but those are relatively temporary. It will depend on how much of the colon has to come out. Sometimes patients will have some changes in their bowel habits compared to what they were before surgery, but I would say most patients seem to get through it fairly well. I'll defer to our patients who've undergone some of these procedures to give you their viewpoint on that. But for a rectal cancer surgery, it's a little bit of a different ballgame because as you get closer to the anus, the surgery gets a little bit tougher. The recovery gets to be a little bit tougher, and patients are more likely to have changes with their bowel habits. And there are some patients that the cancer is so close to the anus that the surgeons are not able to reconnect everything, and they have to have a permanent colostomy, a permanent bag for which the stool to exit the body. And certainly from a body image standpoint and many patients a quality of life standpoint, there's certainly an impact from that.
So current standard includes surgery, chemotherapy, and radiation. So Dr. Hwang, could you also talk a little bit about developments in immunotherapy that can be used or that is being used for colorectal cancer?
So immunotherapy, it's been very interesting over the last 20 years or so that I've been working in cancer, either as a trainee or now on faculty. When I was a trainee, I think that there was a lot of expectation, truthfully more so than in some of the other cancers in which immunotherapy is used, that immunotherapy should work in colon cancers. And that's not been shown, it's not been borne out quite the same way as we've been hoping. The group of patients in which immunotherapy most clearly is helpful are the patients that have what's called Lynch syndrome. In those patients, the current immunotherapies that we have, what we call checkpoint inhibitors, which are anti-CTLA-4 inhibitors, anti-PD-1 inhibitors, they do seem to have a very high likelihood of causing tumors to shrink. But unfortunately, for better, I shouldn't say unfortunately, but for better or for worse, that group of patients in whom immunotherapy seems to work well constitutes maybe 5% of all patients with colorectal cancer. For the rest of the patients with colorectal cancer, it's not yet clear that immunotherapy works. There's been one fairly large study in which immunotherapy was compared to a standard of care chemotherapy in patients who had pretreated colorectal cancers. And in that study, immunotherapy actually was not better than and looked like it was a little bit worse than standard chemotherapies. And so right now, most patients, it's not at all clear that immunotherapy works in patients with colorectal cancer, although there are still studies that are ongoing as we try to figure out, Are there another group of patients in whom it works better? Are there ways that we can tweak the immunotherapy to make it work better? And there are a number of studies ongoing, including one study of which the Levine Cancer Institute is a part, in which patients without prior chemotherapy for metastatic disease, so initial chemotherapy for metastatic disease, receive a standard chemotherapy with or without an anti-PD-1 inhibitor. But we'll see whether that actually works better.
What about CAR T cell therapy, Dr. Hwang? Because we've discussed CAR T on this platform many times before. Is there a rationale that says that CAR T may work in colorectal cancer?
So I would say that for the most part, I would say the answer is too soon to say whether it works. I think the rationale for the hope that it will work is the same underpinnings that led us to believe that vaccine therapies can work in colorectal cancer. There are studies that have suggested that the immune system can respond to colorectal cancer, so that certainly would be the underpinning of why it's absolutely worth exploring. I think that the issue with CAR T will be, number one, will it or any other immunotherapy work? And that's very much an open question. And then for CAR T in particular, is going to be the toxicity question as well. So I think it's very, very much too early to say. I think that they are just starting the earliest studies in patients with solid tumors, and we look forward to the opportunity to have good results, but certainly that information is not available, and probably won't be for a little while.
So Dr. Hwang, I want to prod this a little further. So what are the potential implications if we say that CAR T cell therapy is proven to be effective for colorectal cancer, and what are the implications for other solid tumors in general if CAR T works?
Well, I think that the implication for any treatment that works, whether it's CAR T or some other immunotherapy or some targeted therapy, is obviously will be able to improve patient outcomes. I think that still remains to be that's still a big if right now. Now, if something does work, then the question is, where does it fit in? Where does it work? When you look at CAR T and some of the hematologic malignancies, it's not necessarily the first treatment, or it's not clear that it's the first treatment that one should be using. And those same questions will come up should there be evidence that CAR T works in colorectal cancer or some other solid tumor.
Yes, thank you, doctor. So one of the risk factors for colorectal cancer is a family history of the disease, as you just mentioned some time back. So what are some of the recommended genetic evaluations for such people?
So it depends. So I guess there's two ways that I can answer that. One is it does depend a little bit on the family history. All the specific family history, there are certain patterns that we may think about depending on a patient's family history. For example, with regards to uterine cancer, may point us in the direction towards Lynch syndrome. A very young onset for colon cancer may push us towards familial adenomatous polyposis. But the reality is, we at this point, for the most part, when a patient comes in, if they have a family history that is suggestive, or if they're very young, we'll usually send off a panel of many genes. I don't want to call it a fishing expedition, but trying to make sure that we've covered all of our bases so that we're not missing on a possibility. And so patients get sent off for a panel. It's not usually sending off looking for just one gene or 6 genes or something like that.
So we have a listener send in a question. I know it's kind of resonates with what you just said, but he wants to know how important is getting genetic counseling for colorectal cancer screening.
So I don't think that it's necessary to, if I'm understanding the question correctly, I don't think it's necessary to have genetic counseling for patients that are just undergoing screening. I think the importance of genetic counseling is for patients who've been diagnosed with colorectal cancer to undergo genetic counseling. Now, having said that, if a patient is known to have an increased genetic risk for colorectal cancer, that will absolutely influence the timing of screening. If a patient is known to have Lynch syndrome, as I mentioned, if they're known to have familial adenomatous polyposis, then they are recommended to start screening sooner than the general population. So if somebody has a known genetic predisposition, then that does influence screening recommendations. But I don't recommend that somebody goes to genetic counseling just because they're getting screening.
Yeah, right. There is emerging evidence of clinical relevance of biomarkers in colorectal cancer, but apparently no widespread adoption into clinical practice. So, Doctor, can you talk a little bit about where we are in terms of molecular targeting, biomarkers, and personalized therapy in colorectal cancer?
Actually, I would disagree that biomarkers haven't necessarily gotten to widespread adoption in colorectal cancer, although I will acknowledge that it's probably not as universal as we would like. There are always stories and statistics of some small group of patients providers who don't obtain what I think most people would agree are standard of care biomarkers. So there are really two main biomarkers that we'll test for. Now these are tumor biomarkers, not blood test biomarkers. Unfortunately, there aren't any universal blood test biomarkers at this point. But the tumor biomarkers that are usually tested for, first of all, end up being what's called for microsatellite instability. That may help us determine which patients may have Lynch syndrome. It does help us make decisions with regards to some patients that may benefit from postoperative chemotherapy, or more to the point, don't benefit from postoperative chemotherapy. And that may also suggest a group of patients that are more susceptible, more amenable to receiving immunotherapy. So the microsatellite instability testing is one set of biomarkers that I think is generally tested for, and I think is, again, it may not be universal because every so often I'll see a patient that didn't have that evaluated, but much more often than not, they are tested, and I think most oncologists would agree everybody should. The second, at least with regards to colorectal cancer, the second one that we test for universally, or again, I think, or we should be testing universally, and occasionally we'll see folks that haven't, but that's a minority of patients and of providers in my experience, is something called KRAS mutations or RAS mutations.
RAS mutations.
And those RAS mutations, it doesn't tell us who will benefit from different therapies, but it will tell us which patients are not likely to benefit from what we call epidermal growth factor, or EGFR, receptor inhibitors, drugs like panitumumab or cetuximab. If a patient has a RAS mutation, they will not respond to those therapies. And so again, it doesn't tell us who should be treated, but it does give us an idea of who shouldn't be treated. And so with those types of markers, I think that helps us with personalizing therapy and trying to figure out what the best treatments are, or at least can we avoid treating patients with something that's not going to work.
Thank you, Doctor. I have just one more question before I hand it over to Amy and Johnny for their questions. That is just directly, if you're going to screening for and preventing colorectal cancer. My question is it really possible to prevent colorectal cancer?
So yes, in some patients it is. Not every case is preventable. I unfortunately feel fairly comfortable in saying that, but some cases are. And I think that one of the things that you see is that there has been a decrease in the group of patients who are over 50 over time. There is a decreasing incidence of colorectal cancer, even though there's been an increase in the younger patient population. And the data suggests that is because there are fewer cases being diagnosed because they're being prevented. And the sense from the data is that prevention is because of colonoscopies finding precancerous polyps in the colon and then removing them before they can turn into cancer. And so that to me is really the biggest importance of patients getting their screening colonoscopies. Yes, we can identify cancer sooner, but can we also identify precancerous lesions, get those lesions taken out so that they never develop into colon cancers? So that's really the number one way of trying to prevent colon cancers. I think that there's some data suggesting that aspirin may decrease the risk of colon cancers. That's clearest in patients who've already had a colon cancer in the past, that we can definitely prevent some of those precancerous lesions, but it's less clear that holds true for the general population. The same is true for vitamin D, although the data there is much softer. So I would say colonoscopies and removing colon precancerous polyps is one way that we can prevent colon cancers, and there's some suggestion that aspirin may, although again that's clearest for patients who've had prior colon cancer themselves. It's not as clear in the general population that aspirin will prevent colon polyps.